Good morning from all around the world and welcome to Structural Heart Valve Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Fuster Heart Hospital in New York City. My name is Pedro Moreno and I will be your moderator today. We'd love to hear from you, so please send us your questions directly from the website or on YouTube. And remember, you can review all our previous Structural Heart Valve cases in our website at ccclivecases.org. And now let me transfer you to the cath lab for this bright question.
All right, good morning, Pedro, and good morning or just good day to all our viewers globally, and we are so thankful. Our CCC Live keeps moving up. Now 25,000 per month, 30,000, and recently experiment with Instagram, having all those very short clips up to 1 million plus in various imaging and so great. Our goal always have been provide the latest data and the trial point of view. So this is today we are going to show a special case for that purpose. Introduction point of view, myself, then I have Dr. Keeney, Dr. Gilbert Tang, so our familiar faces. We actually have new face now, Dr. Bhavandar Penta. Penta is our Associate Director of Structural Intervention at Mount Sinai. In the past, Parasuram used to be, he has moved on, and he has joined us now. And then we have our the fellows, structural fellow, Pratish, and who else? Krishna. And so all of them, good. We actually have 4 structural fellows, 3 endovascular fellow, and 8 interventional fellows. So highest army of the fellows with continue our teaching. And then of course, Stem Larakis and the team at our Echo. And if you can show the slide, and we have our from the anesthesia point of view, Dr. Raphael Honigman, and rest are about the same as you can see here. So Dr. Larakis we will get a word from him and going to come. What we want to show today is the transfemoral TAVR with 27 millimeter NAVITOR Vision valve in a high surgical risk AS patient for optimal hemodynamics and coronary access. And this actually comes very timely because the NAVITOR valve just last month got a CE mark approval for low and intermediate risk patient, just last month. So it really comes in timely fashion. So this is our episode number 73, 85-year-old patient with a progressive shortness of breath. Patient also has a CAD, had a cabbage and PCI, actually not cabbage, just PCI of the left main and LAD. And at that time, we were very tight valve. We did a balloon aortic valvuloplasty also. Many times we do, if they have a high gradient, we call it more than 4.5 meter per second or velocity, then we do a BAV and PCI, because over the years we have seen you do a tight PCI and it takes about 1 to 2 months for patient to come back for the valve replacement, TAVR and they have some events. So usually if the gradient is high and our cutoff is like 4.5, around 4 you can leave it, but more than 4.5 plus balloon valvuloplasty, then we do PCI. So we do the valvuloplasty first and then do the PCI. That's exactly this patient had. Patient also has hemolytic anemia, and rest things are about shown there. Has a severe aortic stenosis, and the medical therapy point of view, very good. AFib, patient could not tolerate NOACs, so he's on warfarin, and hemoglobin and things are okay. Of course, EKG point of view, it's a right bundle branch block and left anterior fascicular block. So how are we going to take care of this prospectively, knowing that this patient will have a very high chance of developing complete heart block?
Yeah, I mean, this patient will have a neck TVP already. So irrespective whichever valve you put in, the patient will be high risk, and the patient is aware of that. We actually inform the patient that.
The question always comes at decrease the length of stay. If this kind of patient, let's say, have a 25% chances of pacemaker, should you do it at the same time rather than waiting 2 to 3 days? Because what happens, usual process, you do, now you wait next day, they still try to see whether do it or not. Then by 3rd day they decide. Then 4th day you get a pacemaker, wait another 24 hours. So we have seen the patient who require pacemaker is never a 3-day length of stay. It's 4.6 days minimum. because of the various regions. But anyway, that's the practice we need to work out. Patient had a cath and has a PCI, and as I mentioned, had a June and balloon valvuloplasty with a 20 millimeter ZMAT balloon. So let's go where the money is, and this patient has a severe aortic stenosis. And now Stam, it's your turn. You show us live what is going on with the echocardiogram which you obtained today.
Yes, thank you, Dr. Sharma.
Show the
Good
echo,
morning.
please.
Good morning from New York. Yes, normal LV function, as you can see here, the aortic valve leaflets are thickened, calcified, and decreased excretion, some mitral annular calcification posteriorly, normal LV function from here. As you can see, minimal aortic regurgitation, severe, as you can see, calcified leaflets with decreased excursion, mild to moderate mitral regurgitation. And this mild tricuspid regurgitation with mild to moderate pulmonary hypertension, PA pressure about 45. And this is a short axis view of the aortic valve. As you can see, thickened leaflet, decreased excursion. The same here, minimal aortic regurgitation. Normal LV function here, short axis. And this is a four-chamber view, normal LV, normal RV, moderate mitral annular calcification with mild inflow obstruction from the calcification of the mitral valve and mild to moderate mitral regurgitation. And this is a five-chamber view for the aortic valve. As you can see, minimal AI. And we got a velocity of 4.2, maximum gradient of 72, mean gradient of 46. Putting all together, aortic valve area of 0.6 centimeters square, severe aortic stenosis with normal flow, 38 ml per meter square, so high gradient, normal flow aortic stenosis, no pericardial effusion, and IVC normal pattern with inspiration. Thank you very much.
Beautiful. So this is the kind of case where we know the maximum benefit of the valve replacement or TAVR or surgery happens with such a high gradient. So actually, you know, we can ask our AI guru that why not we come up with some kind of AI algorithm based on the right bundle and left anterior fascicular block who have required pacemaker. If we have those criteria, rather than waiting 3 days, do the pacemaker at the same time and you're going to decrease the length of stay and resources. I mean, that is possible, right, with our AI, the overall database, because all the information is in the medical record.
Yes, we are working on that. So you will have something within the next year.
Or I can tell you another answer could be that just like they have the temporary vena cava filter. So what if you just put a pacemaker into the ventricle? And if doesn't need it, you take it out as electively as an outpatient, and that will decrease the length of stay. So many things could be done, I hope. Or the question is they're working on the valve itself become the pacer. Where are we on that? I heard about one time that the valve could be, they have just little lead which goes into the septum and that start pacing so that you now don't have to worry about temporary pacemaker, but more importantly, permanent pacemaker. But I think there are some issues in there, but development, lot of things are happening in this field, and more importantly going on is 8 French. So we actually have done the 8 French tower now. Gilbert, you want to just comment on that? What is that 8 French tower, which is like, looks like you can start doing from radial now?
Well, I think that it's a company called Mirrors, and they have a balloon expandable platform made of a completely different type of metal. The metal alloy actually has been used for a long time in orthopedic surgery. And now they are putting into the medical device space, specifically in the valve space. The reason why is that it's low profile is that the stent has a much higher radial force than the existing balloon expandable valve. So as a result of that, you don't need so much metal. And we know that less metal, you can crimp into a smaller profile. So the 8 French balloon expandable valve system has an expandable sheath. It does goes up to 14 French after expansion, just like the current balloon expandable system. But the potential advantage of this system, it does not foreshorten. So when you position the valve, you get what you see and you land exactly where you end up. So I think that's make it much simpler from an operator standpoint.
Beautiful. So a lot of things are happening with but what do you think prediction-wise? They're going to go to the trial, early feasibility
yes,
study has been done?
The early feasibility is done. I think they're going to present the 30-day outcomes at TCT, and then they will start the pivotal trial in the fall. So. Yeah, in a
Because
few
you know
months.
that once that those kind of things really shows good outcome at 1 to 3 years, that basically will all current devices will may even become obsolete.
Yeah.
Because we know just like 14 French MCS Impella catheter, now 3 devices, 9 French will be available by mid next year. And you know what will happen to Impella after that. So this is a big issue vascular point of view. So let's go back to our presentation and then we'll come back to the case actual performance. So if we go back to the slides, yeah, so CT aorta.
So let's go back one.
Yeah, I know.
Okay, so here's the annulus. You can see it's a quite a generous annulus, area 450 or so, perimeter 76, LVOT slightly smaller. So, you know, technically you can implant any valve you want, but certainly I would favor a self-expanding weir because the balloon expander here will be between the two sizes. So you don't want to oversize and then under expand it or undersize, and then you may end up with PBL. You can see there's some annular calcium on the long axis on both annulus and LVOT, so nothing too horrendous. Next slide. Large aortic root, you can see no issue with coronary obstruction, tall sinuses, tall coronaries. Next slide. And actually, we can talk about the sizing chart here for the NAVITOR. For those who are not familiar with this system, you can see here they're a little bit overlapping sizes in terms of perimeter and area. And this one falls right in a sweet spot of a 27 millimeter valve.
Yep, and that is what we are planning today.
Yep.
With a 27 millimeter valve and aortic root.
I can see here, yeah, pretty straightforward in terms of the root angle. Free leaflet calcification. Next slide.
Now tell me a little more about the NAVITOR. So that if you have too much calcium, some reports have been that too much recoil.
Well, I think the key for the NAVITOR is a different opening force. It's a bigger cell. So you need to pre-dilate and post-dilate more aggressively. I think that's what the company recommend, that you pre-dilate looking at the average diameter, not the minimum diameter of the annulus, but more the average diameter. And the advantage of that, you can use the same balloon. You don't have to open a different balloon. And so from an economic standpoint, it's actually better. But you do need to pre and post-dilate more liberally, shall we say. But we've done some calcified cases. Obviously, we're part of ENVISION trial, which enrolls patients low intermediate risk, and those patients require high flow, high grain, like this patient, for example. Had a patient been low intermediate, were qualified for the trial. So definitely, I think they are looking at that right now.
Okay, Penta, about CT access, how you feel?
Yeah, thank you, Dr. Sharma. The right side axis has a disease in the common iliac, so we went for the left axis and there was no issue. The gore sheath which we used went smoothly, so not much issue with the access.
Okay, very good. So summary, this patient has a severe aortic stenosis and found to be a high surgical risk and appropriate for intra-annular self-expanding TAVR for better hemodynamics and potential easy future coronary access. Because this case, who already have a left main PCI, when we are doing the TAVR, we had to think about that there is access to the coronaries. So therefore, we felt that the NAVITOR will give us a good ground with the better hemodynamics. And of course, if a patient re-stenosed with the left main, can be easily tackled. Now with that note, Anu, tell us where we are now.
We are ready to cross, so we'll show the crossing, right? And then change it to
coronaries today or no?
Oh, left side, yes. Why did it connect it there?
Okay.
Give me a syringe, please.
All right, show, go to we did the aortogram. We can show the aortogram.
Sure, we can show
so
the
that will have
aortogram.
some idea about the coronary stent on the left main.
So this is the free cut. You can see the nice left main stand there.
Yeah.
Proximal takeoff. You can see the leaflets are quite calcified, consistent with the echo report stem this morning. And then you can see now the cuts overlap view. We can talk more about the deployment technique later on, but we have really not used cuts overlap view anymore because of the property, specific property of this valve versus other self-expanding valves like the Evolut system. So we'll look. We do what we call a frame alignment view now. It simplifies the procedure in terms of deploying this valve specifically, and we'll show you how we do that.
So it's I know it's a AR2.
It is AR2. I was thinking after with the, okay, that's where we are.
Went in.
Any questions so far, Dr. Moreno, from the
No,
audience?
but I was going to ask you, in
Yes.
this case, what makes this case special and what would be potential complications?
Yeah, so I mean, clearly the potential complication, you always think about the valve migration. Calcium is moderate level. It's not I don't think we worry about the aortic rupture. But definitely one of the biggest, I won't call it a complication, but need for pacemaker. Pacemaker will be very high, whether any self-expanding valve you use. Even with the balloon expandable, you'll have a probably 7-8% rate, but with the self-expanding will be 15 plus.
Now his question is, why did we select this valve compared to, so you see that the calcium in the LVOT and the annulus, then not balloon expandable, self-expanding valve could have been used. The biggest reason is coronary access here.
CAD.
Excellent.
Yeah, so that is the main reason that
Floor,
you
please.
need a combination of both. And valve sizing wise, remember what Gilbert just mentioned, that it is 23 versus 26. If you go 23 is too small for self-expanding, 26 may be large because of the chunk of calcium in the LVOT. So taking all that into consideration,
Can we show the
this probably
hemodynamic
is the
screen,
best.
please?
Yeah.
Also, the picture-in-picture for hemodynamic screen.
Show the hemodynamic screen
What is talking, you don't overtalk.
also on one side. Make sure you tell your people, company people also to log in.
To 0.
They did, because I'm going to talk about the trial also.
0 all.
Okay, let's see the hemodynamics. Real aortic stenosis. I did a balloon valvuloplasty about 3 months ago. So it's recoil, which is what happens.
Huh?
Yeah. What happened? Came out?
Oh,
Okay.
Came out, yeah.
Yeah. Now this one you have to go without, it will
Yeah.
not come out.
Next gen.
So many times we
How it
say it's a
happens.
memory, probably will go back in, it's not. You need a stiff, you need the wire.
yeah.
So
How did it
talking
come
about the balloon valvuloplasty, that definitely is coming back for optimization of these patients many times with the heart failure, very high gradient, and particularly with a setup where you don't want to do TAVR and PCI together.
Many they are
With a very
doing,
high,
right?
a lot of people do it, but we try to be avoid there. I know the Notion 3 trial has shown that it's okay to do even the PCI, particularly during peri-procedure or just post with the patients. The complete TAVR trial is evaluating that should you do it at all. But they all did after TAVR. So I would say that unless a very significant CAD, there's a left main like this particular patient had, we actually also started doing the PCI now post TAVR. Again, there is no clear-cut answer for that, because some studies have done pre, some post, but overall, having gone through all that, we believe that post, unless there is a left main or severe CAD, it's a post is better. And I know some people say, well, what will happen if you in 80-90% proximal LED and you are doing the TAVR, that time vessel will close. Believe me, I have never seen a single case of having acute coronary catastrophe at the time of the TAVR. And we know exactly that the complete TAVR trial is evaluating that patients after successful TAVR are being randomized, left main is excluded, being randomized to the PCI or no PCI. Although since the Notion 3 trial came, where showed the PCI is better rather than wait and watch policy, the enrollment of the complete TAVR trial has really suffered. Although we still, they need to do 4,000 cases, they barely are to like 400, 1/10 or so, or maybe have been a little more. We have done at Sinai about 12 or 15, somewhere between 12 to 15 cases in the trial.
Along those lines, Dr. Sharma, no coronary catastrophes for severe coronary stenosis during TAVR implantation. What about the opposite? You want to do a complex PCI, but you have severe AS. Would you mandate the aortic valvuloplasty?
Yeah, so that's a very good point. I think that's the crux of the operational and recommendation. And our recommendation is very simple. So if you have very high gradient, and gradient I'm talking about everybody, by the time they come, they have severe AS, where the valve area is 0.7, 0.9. Don't go with that. I say basically go with the velocity. And your velocity is more than 4 or 4.5 particularly, do the BAV and then do the PCI. And we haven't had any problem. We have published that in catheter cardiovascular intervention, our results of 26 patients. And then many of these patients then will require TAVR at a later date. So patients in that group where we did a PCI and BAV, survival at 1 year was 12% those who later on had TAVR. Those who did not have TAVR, so whatever reason, because their comorbid condition, survival rate was only 40% on those patients. So clearly is that once you have done the BAV and PCI, for patient to have a good long-term prognosis, you have to do the TAVR in these patients. So you can see here that we recrossed, Anu recrossed it, and we are going to go back. The process will remain the same. Use the extended length wire, put a pigtail, let the wire pigtail curl up, have the wire shape, and there's a lot of science going behind it also. That wire, can you use the same wire for pacing? There is some questions about that wire can move, and so we have not gone to the pacing wire. One is also very expensive.
So I think Dr. Sharma, maybe you can comment about the wire-induced heart block in this particular kind of case, right? In terms of, we've seen cases where, we haven't even put in the valve in, and the patient already developed block because of the wire tickling the LV.
LV, yes.
And we'll see what the BAV looks like, because we have seen that as well, that putting the stiff wires are very different from a J wire like you see here. So we always ask our colleagues here to be on standby in case we need to back up pace the patient, okay? So Fausto or Rafi, if you can just be on standby, because the Safari is going in now. And we've seen that sometimes even the Safari stiff wire or any kind of stiff wire itself can cause block. And so we need to be ready to have that.
Yeah, so overall our data actually were not analyzed recently, but few years ago when we did our data on the balloon valvuloplasty, taken all patients together, about 3% need for pacemaker. That, that heart block persisted and patient required pacemaker. Yes, this patient definitely will be higher, but when I did the valvuloplasty, the patient didn't need anything at that time. But here now will be a little more different.
Yeah, this is a 24 true balloon, which is roughly measured the mean diameter you saw earlier on the CT scan. And so, this is the one we're using.
180, 150.
150. Good, all the way. So you can see Dr. Keeney's technique of BAV, okay? So it's a slow, it's not slamming the thing because it can slip up, back up at 60. 60, please. 60. Good. So you can see there's a bit of change already. So you can see that even with Dr. Sharma did the BAV with 20 balloon, the valve is still 0.6. This is high flow, high gradient. And you can see there's still a waste. So some people say, well, Dr. Sharma did the BAV, why do I have to do it again? So it's very important to look at the echo again, what the valve area is, and actually on the fluoroscopy, you can see the leaflets were not very mobile at all. If the leaflet were more mobile, I think we can skip it and we just do a post-dilatation, even with the NAVITOR system. And so do they want to look at the system itself, or?
You want to show that?
You can see it on the ceiling camera.
Yeah, so maybe the ceiling camera can show. So this is a very ergonomic system. The sheath is extremely hydrophilic and lubricious here, so most people even use it by itself. And you can see that here, that's the flush port, that's the wheel that uses the deployment, that's a knob before release. So we call it essentially a single operated system, because you can see Dr. Keeney's hands later that you can just use one hand, and you can even have, actually, we obviously have enough people here that if you down on people, you can even hold one hand with a wire and one hand to deploy, and then someone else hold the first operate position. The manufacturer recommends this flush port here at 12 o'clock, but we do it at 6 o'clock because of the tap release. Unlike the Evolut, which has 2 taps, this has 3 taps to release. You have to see all 3 taps release on fluoroscopy before you can pull back the system. So, okay, all right, so we're now going to go in, and we're going to go LAO view. Okay, just to make sure we can see the arch and how it crosses. Okay, ready?
Yeah.
You have wire?
Yes, I have that.
So it's a very easy trackable system. So you can see it here. It just goes right. So we typically goes a little deeper on below the annulus and then pull back to center the catheter. Flo, save that, please. And then let me pick the pigtail now. So we actually, people ask about what technique we use here to deploy the NAVITOR. We've done well over 100 cases now. And what we typically like to do, we call the frame alignment view. So you can see the vision markers here. Okay, they're completely aligned. So Dr. Keeney will start. You can see the pigtails that are non-cuts. You can do a puff just to show the audience. So
Let's do a cine. One second.
So we like to go deep and then pull back, and then we can start. So we don't want tension in the system. Good. Okay, go ahead.
Good?
Yeah.
Yes.
So you just need to turn the view towards you. No pacing required.
Yeah, tell us about that also, that this is a valve which you can do it, deploy completely even without any pacing.
Yeah, so you can see here, let's take a quick puff here. Okay, so at this point, I'm going to bring back a little negative tension. You can see the vision markers right around 3-4 millimeters. Slow down here. Very nice. Okay, go.
And see that until now you're not paced at all, right?
Perfect. Okay.
No, it's not.
So until you hear some clicks, that's when you are 80% good. Okay, Flo, say that, please.
It's a pacer, yeah.
Okay. So at this point, we bring back the wire.
Yeah.
Okay. So let's bring back the wire, and then let's go to the frame alignment view. So what I mean by frame alignment view is that
I want to take a cine.
yeah, no, take the parallax off here. Perfect. Look at that. Okay, let's do one more, just to make sure we have no parallax.
No.
Now tell us what parallax means of frame alignment.
Yeah, very good, Dr. Sharma. Good question. You can see that here the dots are completely aligned, facing all one line. Okay.
One line, beautiful.
I think.
Can we take the Christmas tree
It's a
out,
little,
please?
Isn't it a little
I
high?
think-
No, let's
it
see.
is-
No,
it is
it's a
high.
little high, but actually, it's actually not bad. You can see.
High.
Let's see. Yeah.
I would release this actually.
Looks very good.
I would actually, because remember, you want to avoid pacemaker if you can as well. So, and you can see there's no leak on the left side.
It's
So the
barely-
annulus is fully engaged. So
It's
and it's
like-
gonna pivot.
It's like only 5,
Yeah.
not even.
Yeah.
Yeah?
No, we can leave the pigtail at the bottom if you like.
You want to leave it? No, I'll pull
No,
it back.
I'll pull it. Okay.
Yeah.
All right. Okay.
A lot of people do,
Yep.
but no.
Okay. Wire back. Okay. 150. No. Did you press? You pressed it up.
Yeah,
Here. Okay. Okay. Good. Wiggle. Release. Slow.
Oh, okay.
Good. Perfect. Good. Okay. Valve is released. You can see all 3 taps there. 120, please.
You see 2 tabs out,
Okay.
right?
Yeah. 1, 2, 3. Flo, say that, please. Okay. Does everyone appreciate 1, 2, 3? 1, 2, 3. Yes. Okay. So now, doctor, let me just take
Hold
the
on.
Yeah.
I see 2. Where is your third?
Third is right there, Dr. Kinney. 1,
Okay,
2,
okay,
and 3.
okay, fine.
Everyone okay?
Third one is like 11 o'clock or 10:30. Yeah.
Everyone see it, right?
Yes.
Okay, good. So now, Dr. Bhavan is going to pull the wire back, and while Dr. Kinney bring it into the nose cone inside, okay, and advance the wire now. I think it's a great implant. Okay, all right. So now we can recapture. Go ahead, Bhavan.
Yeah.
So basically, you bring this little thing here towards the Mary nose cone, and okay.
Come on.
So let's
Yeah.
come out and
Let's come out and
back
then
up
we'll
at
do the
60,
autograph.
please. Okay.
Now we have the fluoro save when the 1 and the 2 were separated, no? We have the
Yes,
fluoro
we
save?
do. Yes, we
Yeah,
do. We
now,
can review
now they
that
look
later
very
on.
close, yeah.
No, we can.
We'll
yeah.
show that after this, yeah.
Okay, so
Okay,
let's.
okay.
Good. Okay.
Get the true balloon.
Same balloon ready, and then 1 second, please. Let's just do it in this view.
Oh, it was a change in the projection.
Yeah, in the
Yes.
projection.
Yeah,
Correct.
I got it. No problem.
Beautiful.
Perfect. Look at that.
Yeah, very nice.
So the beauty of this system is that it really just pivots gently. You can see it doesn't dive in, it doesn't pop out. Even people say, well, that's really nervous, but you can see we'll test the pacemaker afterwards. Let's just finish and expand the valve. You can see we talked about expansion. Dr. Sharma, you want to talk a little bit about why we post-dilate, maybe even without PVL?
Yeah, so question comes always is, in this case, self-expanding, we learn more and more, you should post-dilate. Now, there is another concept of the double tap,
Yeah.
is that your second inflation definitely will open better effective aortic orifice by the second dilatation. And we'll try to make that point by serial measurement of those aortic orifices.
Keep pacing, keep pacing, keep
Keep
pacing.
pacing.
Back up,
Leave the wire.
Off.
back up, pigtail, please.
Get a pigtail.
Back up 60, please.
Now question is, Gilbert, can you do this case? Patient has an ejection fraction of 15%.
Yes.
You're worried about pacing at all.
Yeah,
Can you
yes,
deploy the valve
absolutely. We've
without
done a
it,
case
right?
2 weeks ago.
Yeah.
Yeah, 15%, zero pacing, zero, everything, just basically the patient's own rhythm. And the valve does not move. I mean, it's pretty remarkable that you have a self-expanding system that you actually don't need any kind of control pacing to release the valve if you don't want to. I mean, obviously in this case, we just want to show the concept, and we were quite high on the depth because we want to avoid a pacemaker, and that's why we control pace the release. But you don't have to go so fast. So let's do some hemodynamics here, and then we'll have Stam and Layla and Hafiz to do the echo. All right, go ahead, please.
And actually,
Stam.
we have seen also very nice
Layla and Hafiz,
hemodynamics.
Stam, go ahead with the echo. Go ahead. Thank
Echo?
you. Yep.
Yeah. Let's flush both of them and re-zero.
Three and four. This is the cuss overlap view, actually, almost. But you can see when Dr. Kinney inflated balloon actually expanded a bit more at the inflow. So
Came back.
we've seen now that the all valves
Sorry.
can be underexpanded with respective system. And that's the mode of failure when they come back to see redo TAVR.
Came out again.
Catheter came out again. That's
It's
okay.
like it's hyperdynamic.
Yeah.
And we're pushing it out.
All right, tell us the echo team.
Looks
Put
good.
a
Yes,
screen
looks
Can
echo.
we get the pacer down to 40 and see?
the echo on the
And
screen,
conduction
please.
and the
No,
line?
no PVL.
Put full screen.
Yeah.
Echo full screen.
Short
Yeah,
axis.
on rhythm, right?
Short axis view of the valve.
Wow,
No AI, no
no
PVL.
bundle branch. Beautiful.
no block.
No
Okay,
block.
apical. Okay, beautiful.
Okay.
Yes, no PVL. Let's measure velocity. That's it, bro. You had it there. Okay. Let's measure that. Let's measure first.
We'll review it with the audience. I want to show how Dr. Kinney actually demonstrated.
Peak gradient of
technique.
6.
Beautiful.
Subcostal.
And your valve area will be what? 2.2 or 2.3 or 2.1?
Nailed it.
But we have to measure more things, but most likely 2.2.
2.2. Very good. All right, show us the technique now.
Yeah, let's
Go
show
to
one
the fluoro.
fluoro and we explain what Dr. Kinney was doing and
efficient,
what I
great.
was doing just to
Very useful.
optimize the implants so you don't have to, we try to not to recapture with any self-expanding now. So let me just start playing here. So the key here is that you have to make sure that NAVITOR catheter is more centered, not in the outer curve. So you go deep and you pull back. It's a very flexible system. So see how it's more the inner, middle and the center. So now, as she was flowering, she was very gentle with the wheel, okay? So it's no rush. There's no pacing required. You don't have to go to 80%. And you can just see how naturally the opening force is very different versus the Evolut system or other self-expanding system that you might use in your own region. So you can see the catheter is very centered, and that's the key. If your catheter is in the outer curve, you end up missing the left. Okay, so that's something that we've learned now. And with this view, this is a LAO 29. So this is not a cuss overlap view. And with the free markers like that you see, you don't see much parallax at all. So you can really make sure you don't miss the left. So now here, the dots are not quite there. So here you can see it's definitely below the vision. That's about 2, 2 and 2. So anytime your left cuss, as long as your left cuss is not negative, you can deploy this valve, okay? This is almost 0, but we have enough experience that this is actually ideal position for the NAVITOR, as long as you release slowly, like what she did. And you can also understand that the operator one does not push or pull, okay? If you do that, then you have a lot of pain afterwards. So you can see now this is the release. And I think I'm not sure this is showing the entire sequence.
Come up, yeah.
Yeah, but you can see that you now pace, and then let's see if you make the run. I think it will make the run. So you can see that the valve self-center, okay, everyone was worried it was too high, okay, but look at when it releases, it pivots. See? Right? So we were really not concerned about pop out here because the valve is calcified. You can see the free taps release right away with this 6 o'clock flush port position. I think it's easier. And then you just, release the valve, and you can see here if the final depth is actually more like a 3 and 4. So it's exactly where you want it to be with this system. Okay.
Can't ask for better, and particularly the rhythm. You see the hemodynamics rhythm.
Yeah, let's show the hemodynamics. The rhythm is not just no high block at all. So.
Sorry, the pigtail came out. I don't think we should need to recross now.
No.
Just show the hemodynamic on one side. Just see.
Can we fix the fluoroscopy, please?
And show us the 6 lead ECG.
Okay, there we got it back into the LV. No gradient.
Oh, LV went in. Wow, good.
This one.
No gradient. Good. And look at this. Some beats, but most of the beats are intrinsic and no extra prolongation of the QRS.
You still think we leave it? Temporary?
Yeah, negativity. Yes.
The temporary wire, I think because of the baseline high, our protocol, this case should be left till tomorrow morning.
Yeah.
And tomorrow morning looks good, comes out, and then patient can go home tomorrow.
With an even monitor.
All right, so this valve deployment procedure, step by step, has been fantastic. If we can go back to the angiogram, our presentation. Go to the slides.
Protamine.
So what we are going to talk today
30.
about the paper, the trials which were presented in the European Society of Cardiology 2 weeks ago in the field of TAVR. So there are Portico, the NG study, then Vantage trial, that's an important one, and then double choice trial, BHF Protect TAVI randomized clinical trial, and evolved trial. So all those things we'll talk one by one. So basically you can see the overall, this patient with the Portico in the global Portico registry showed the valve has its own advantage, cuff there, and see the open cells. Access and the valve area at 1 year about 2 centimeters. So very good. PVL still happens about mild in about 14%. Does it bother you a little bit?
I think that's a technique driven. I think we don't, remember that was still early experience, right?
Yeah.
So I think people are implanting a little deeper than they should.
And routine post dilatation.
Correct, exactly. That's the other thing too, post dilatation.
And we learned that. And I can tell you the death nail on the accurate neo trial. Right in the beginning, in 5-7 patients, we already said we are part of the trial. I said this valve is not looking good. It has a lot of residual gradient within 30 days. And there was a not uniform policy of post dilating.
Correct. We were asked not to actually.
Yeah, not to. And that actually, the accurate neo valve disappeared. So overall, very safe, great procedural success, and so on and so forth. So that led to the Vantage trial, which is the 30-day and 1 year outcome, not a randomized trial. Vantage study, that patient with a low to intermediate risk. So we learned that enough data have accumulated in the high risk and so low to intermediate. And this basically is that they are also working on the valve in valve, but native aortic valve, majority are 1/3, 1/3, 1/3, or 25, 27, 29. The valve point of view. And as I mentioned, this is special, the sealing zone, less PVL, still there, but less PVL. The whole question comes out to be that in severely calcific valve, what will be the outcome? So I think that's probably the only one we do not know. But otherwise, the cases which have been approved to be part of the trial, and you see the very low event rate, and you're ready to see the event rate, is unbelievable, like too hard to believe. Look at that. Safety at 1 year, 2.3. Mortality, fatal stroke, or at 2.3, which is one of the lowest in any of the trials at present, and the data subsequently shown. And efficacy point of view, that PVL more than moderate happened in 0%. So mild about 14%, but moderate overall excellent outcome of the device. The individual endpoints are here, which I have shown. What I put in the red is most important, that your coronary obstruction requiring intervention is 0. That is what we want to use. Mild PVL, as I said, about in upper teens has been a little trouble, but we're learning that post-dilate everyone and having an all-cause mortality of 1.4%. And knowing that we are the part of the low and intermediate risk trial for the Evolute and so, and all of them had about 2.5 to 3% mortality. This may be a different patient group, but just to say, one of the best data you ever see from the valve point of view, right here, and valve intervention 0, no endocarditis, and more importantly, look at the valve just about 2 centimeter, what we used to get with the all self-expanding valve. Similar data, I would say, with the balloon expander probably will be 1.8. It's a 2, and we know 1.9 to 2, and we know that today's case has a 2.0, and otherwise they are quite effective. So that conclusion basically is very safe and performs excellent. Results support the expanded indication of the NAVITOR valve for low to intermediate risk patients, and this lead to approval. The press release last month of Abbott NAVITOR TAVR system was approved on August 29th, 2025 in the CE mark approval. So that is for the low to intermediate risk. Now what happens in America is the ongoing trial, and we are part of it, Envision ID trial, which is native aortic valve replacement, intermediate to low risk, patient 1-to-1 randomization, 1,500 patients. They say close to 1,000 have been done. So this probably will take another 4 or 5 months, and the data probably will be presented in the TCT next year in those cases. But yes, and the second cohort of valve-in-valve cohort, and I don't know what exactly is going on in that valve-in-valve cohort.
So yeah, so valve-in-valve, I'm part of the screening committee. Like you said, so here, TAV-in STAT for TAV-in TAV with the NAVITOR inside a failed valve. So we can definitely enroll, but it has to be high extreme surgical risk. And I think the key is to get expansion indication. Yeah.
Yep. So this is fantastic, which we are going to have. Then second question is double choice, that pre-interventional anesthesia versus what type of valve, 2x2 factorial design called double choice. Here is the one minimalistic approach. Anesthesia just intravenous. No conscious sedation. 377 compared to standard of care. Local anesthesia, conscious sedation, and so. And then further randomization to Accurate Neo and Evolute. Of course, now we don't use the Accurate Neo, has been taken off the market, but that's where the strategy was. And they have their own endpoints, that what is the anesthesia endpoints and what is the valve strategy endpoint. The most important is, very important message comes again, that whether you'd use the minimal anesthesia or standard of care anesthesia, their outcomes are identical. As you can see here, 30-day endpoint. Of course, you need to have more extended, but overall basically short, because they're worried about the bleeding, the infection, and of course, the neurological event, nothing, identical. Individual endpoints are shown here. So no difference. The minimalistic approach may be even a couple of % lower. But just to say, the whole field is going there. Why? Because the contribution margin, lot of expense because the valve cost at present, and if you can decrease the paraphernalia, the overall what you use various equipment, personnel, probably the technique will become financially viable for the institutions also. But most important, has to be safe. And now these are the individual endpoint, and as you can see that various complications, whether you have minimalistic approach or standard of care, people worry about. If you don't give anesthesia, a patient goes sour, what will happen? And so answer is no. Only two things, that self-reported anxiety level and self-reported stress level. Of course, you have no anesthesia, so they were patient were little stressed out. So I think you can still give some maybe PO Valium before they come in, but that part is the only negative, very subjective. But otherwise, look at the every point was identical in terms of the minimalistic approach. So basically, the onus was on the minimalistic approach, that it is as good as your standard of care, and answer came out that yes, as good as your standard of care. Now, that compared to Accurate Neo versus Evolute, actually here, Accurate Neo did very well. 50% event rate compared to the evolute. But of course, as I mentioned, this trial, the device is not there, so we don't have to worry about this any further. Well, area, safety, efficacy, all were very good in terms of the valve choice. So basically, what we learned is the transfemoral TAVR using minimalistic approach is non-inferior to standard of care, respect to a composite primary endpoint of all-cause mortality, vascular and bleeding complication, infection, or neurologic event. So minimalistic approach strategy for transfemoral TAVI is feasible, safe and efficient, although patients are potentially exposed to more discomfort and a higher stress level during procedure. So knowing this for Anu and Gilbert as a leader for the program, what we should be doing in some cases?
I think we should start thinking in the sense the low-risk patients, young patients, we have to start doing this minimalistic approach.
Yeah, I think particularly
it's a time
NAVITOR,
for
no
that.
pacing required. There should not be any anxiety level, because if you pace, of course they get anxious.
Right.
So I think, and of course, certain complex procedure which should still maintain standard care, but low risk, straightforward anatomy and patient cooperation, I think is also very. They need to be aware that they will be more awake during the procedure, so they can anticipate. In fact,
how are we doing complex PCIs?
No, absolutely.
Complex PCI by the MCS, which we are doing now, it's just with the sedation.
Yeah, no, absolutely.
I mean, they are fully sedated.
Yeah.
Our nurses are so good, they know the sedation.
Exactly. So it's just the
And
right
we just
timing
have
of
to do it.
sedation. So
And I think what we'll do is, as a heart team discussion with our anesthesia colleagues, we'll sit down and select what cases could be and identify. Region basically is very comfortable for the patients, except that, of course, anesthesia, early ambulation, and then they can go home next day, just like a balloon aortic valvuloplasty, that you are doing a little extended BAV. In the BAV, we don't give any anesthesia, just patient gets some intravenous and done, and of course, the accurate neo was a little better from there. So what we learned, that minimal anesthesia, a minimal approach, including isolated local anesthesia, was non-inferior to standard of care with conscious sedation, highlighting the safety and efficacy of minimalistic anesthesia for TAVI. The burden of intra-procedural pain and discomfort is potentially higher in the MA group, so that maybe you give a little more sedation, PO. Then we learned that BHF Protect TAVI trial was negative for the cerebral embolic protection, but they came up now. What about the cognitive function? Because they all knew that there was a microembolization, and so it's a very interesting. So there's on the telephone, they call it a MOCA, Montreal Cognitive Assessment. Attention, repeat a sequence of number, language, then they have a abstraction, delayed recall, orientation, executive, and naming. So ask them various questions, and then idea was the mean change, that what are the baseline, what happened to them at follow-up, at 30 days, and secondly, that more than 3 points drop, which is a T-MOCA more than 3. And what we learned, the control group where they could do it, here 1700 in the control group, 1700 in the CEP group, and they have the MOCA performed, both baseline at 6 to 8 weeks in these patients, and basically saw on the left side, they were identical to begin with. On the right side, change in the MOCA was identical. You can see the curve graphs, so basically no difference. Then you say, well, what about the severe one? More than 3 point drop of the MOCA was also identical. So it's basically showing the cerebral protection device did not decrease the stroke rate in the BHF TAVI. We know that. And secondly, there was no difference in cognitive function at 6 to 8 weeks. What will happen at 1 to 2 years, we do not know. But that's what the trial was for the 6 to 8 weeks. And individual endpoints overall, no matter what it was, did not make any subgroup difference. Then the fourth presentation is that patient with the early asymptomatic TAVR evolved. Those who have myocardial fibrosis, they got early intervention versus waitful watch. Remember, there were two trials were presented. One was early TAVR and secondly was the evolved TAVR. Evolved TAVR was patients have a definite myocardial necrosis in terms of the MRI or have a CKMB or troponin release, and those patients were randomized to wait and watch or standard of care or conservative approach or get a TAVR. And what we learned basically is that in the trial, as you can see on the left side, almost everybody in that group by the third or fourth year, even in the conservative approach, got the TAVR. In the earlier intervention group, got the TAVR within few months. Then all-cause death and unplanned hospitalization, AS-related hospitalization definitely was lower in the early intervention compared to the conservative approach, although death was not different. Why? Because the whole concept here is myocardial fibrosis causing the LV thickening and then give rise to increased afterload and ventricular hypertrophy, and it's maybe a predictor of the worst prognosis. So therefore, the concept was, the current hypothesis is a patient with higher burden of myocardial fibrosis have a greater incidence of the primary endpoint, and those patients may potentially benefit more with the early intervention. So that was the concept. The myocardial fibrosis patient, the higher burden of higher means everybody was require myocardial fibrosis to be in the EVOLVE trial, but higher burden, and secondly, whether early intervention make a difference in those cases. So what we found, this is a very good picture of MRI. Maybe STEM, you can comment on it. They're seeing a high mid-wall fibrosis or low mid-wall fibrosis. Yeah.
On the left,
Right.
on the bottom, you can see that this is delayed enhancement imaging, and you can see the myocardium is hyper enhanced, which is consistent with fibrosis. And also in the bottom on the middle, the same thing. You can see on the lateral wall is also mid-wall fibrosis, completely opposite to the right side, where there is some overload pressure that you see in the inferior RV insertion point, little bit fibrosis, but basically whatever you see white means fibrosis of the myocardium.
The white, exactly. The late gadolinium enhancement was associated with the fibrosis, and if you are low versus high, that was the difference. So what we found, high fibrosis, low fibrosis, big disconnect. You see the event rate was almost 2 times, hazard ratio of 2 times. That high fibrosis has a higher death and the neurologic event at follow-up of the 4 to 5 years. That's one. So every 1% increase in mid-wall myocardial fibrosis, there was increase in the incidence of primary endpoint. Second point was that what about these patients? So those who have no effect of early intervention on all-cause death based on the fibrosis burden. You have a high or low, there was no difference. So intervention did not decrease the mortality. Then you say, well, the concept is gone. No. Wait. Third one is, what about the heart failure? The intervention reduced the AS-related hospitalization in the high fibrosis group compared to the low fibrosis group. So at least we have one positive, that intervention, of course, early intervention in these high fibrosis patients decreased hospitalization, although did not decrease the death. And you know why death did not decrease? Because in the other group, by the 4th, 5th year, everybody got the TAVR. So it will be very tough to differentiate that you take all the patients with the fibrosis and everybody get TAVR in both the groups and so. So with that note, let me just put together intra-annular TAVR NAVITOR valve with a unique design and open cells, has a very excellent 30-day, 1-year safety and performance. Occurrence of mild PVL, I think in the low teens, need to further, maybe some advancement of extra cuff, but more important, routine post-dilatation. So we do quite a bit back in India also with the NAVITOR valve at our center. We post-dilate. So unless there is some region, try to post-dilate, and that will do better job in terms of long-term outcome. And its equivalency in the low to intermediate AS patient is being compared in the ongoing randomized trial. Then minimalistic approach of anesthesia is as good, and therefore it makes sense if your patient can be a little more sedated, but not necessarily by the conscious sedation, but just by maybe PO medication, may do better overall. The third analysis of our CEP, that no effect on telephonic measured cognitive function after CEP or no CEP, so it looks like the CEP is going down, 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 yet the trials are continued to be done for the cerebral embolic protection. Then higher myocardial fibrosis can identify asymptomatic AS patients who are at higher incidence of cardiac event or death, and therefore should get more early TAVR, and of course it decrease the AS-related hospitalization. So just identify the subsequent patient for an asymptomatic. So 3 questions. Following are the safety and performance data for NAVITOR TAVR valve in the low to intermediate AS, except low mild PVL of less than 10%, excellent safety profile of less than 3% major events at 12 months, moderate PVL of less than 1%, very low coronary obstruction less than 1%. The answer there is all correct, except PVL is about 12 to 15%, mild PVL. But moderate PVL is less than 1% or close to zero in one of the study. Second, the double choice trial showed minimalistic approach versus standard of care transfemoral TAVR. Primary endpoint of the death, vascular bleeding, infection, stroke were similar. Lower self-reported stress level during the procedure with minimalist anesthesia versus standard of care. Similar procedure duration in two groups. Similar ICU length of stay. Very important is B is wrong because it was not lower. The stress level was higher in the minimalistic approach, so we had to be careful. Then following outcomes are true regarding the results of asymptomatic severe AS with myocardial fibrosis, except patients with myocardial fibrosis have higher event rates with no fibrosis. Yes, right? Early intervention reduces AS-related hospitalization in myocardial fibrosis versus no fibrosis. Then early intervention reduces death rate, and patients with myocardial fibrosis receive higher aortic valve intervention. So clearly, the answer there is C. Early intervention does not reduce the death rate, decrease the hospitalization, and of course, decrease the aortic valve intervention. So therefore, C is that it does not decrease the mortality, but rest is all same. So with that note, Pedro, I complete my presentation, and we can take any question if necessary.
Fantastic, fantastic, Dr. Sharma. I actually have a question. What about patients with moderate to severe AS, asymptomatic, and with myocardial fibrosis? Would you consider that a possibility to do early TAVR in those patients?
So very good point. So only the data we have for the moderate AS, moderate to severe AS, but with a heart failure and LV dysfunction. And at present, Evolute, the trial is ongoing for the moderate patient, moderate AS, valve area 1 to 1.5, normal EF and low ejection fraction, subsequent randomization. So I think that part still need to be, in my opinion, that may come out to be a positive, but we just have to wait because we're learning more and more. Pendulum is shifting. You don't have to wait to get very severe obstruction. By the time you have severe AS for long lasting, you have created so much myocardial fibrosis. So even if you replace the valve, hemodynamics is good, but patient may have some death rate and follow up. So idea is go early. Yep. And that's the TAVR unload trial was a little disappointing. That did not show any difference, but I think you have to take some other measurements. Other measurements basically means it doesn't have to be a low ejection fraction, only your heart failure. Patient could be normal ejection fraction, moderate AS. So maybe some other trial like we have at present with the Evolute may answer that question, but that field is still, I would say, evolving. And at this time, we cannot make a point that moderate AS, with or without heart failure, with or without LV dysfunction, should get the TAVR.
Fantastic response. I appreciate it. Well, thank you very much for the heart team today. Thank you for you joining us today for this excellent case of the NAVITOR valve. And remember, today, this afternoon, you can review this case in our website at ccclivecases.org. Our heart live cases occur on second Tuesday of every month at 9 a.m. Eastern Time, and the next one will be October 14. See you then. Thank you so much.